My name's Pam Armstrong. I'm from an organisation called CETA, which is the Council for Information on Tranquilizers and Antidepressants. We also deal with antipsychotics and painkillers, advising, providing information and supporting people in the process of coming off these drugs. We've been around for 21 years. I understand that my role here is to chair some discussion, and I'll introduce you first of all to Professor Ashton, then you Professor as well? No, Dr. Joanna Moncrieff and Adam Jugaru, who are also going to be talking at this session. And then I think we're going, and Professor Healy's here as well. And then I think we're going to have a discussion, which I think we all feel is probably the most useful thing, to discuss experiences and I suppose more proactively what can actually be done about what is going on generally in the country and in the world to do with psychoactive medication. Thank you. Let Heather start.
Well, just to put you in the picture, I ran a benzodiazepine withdrawal clinic for 12 years, which was quite unplanned. But I used to work in a general pharmacology clinic. And one day a lady came in who'd been in a traffic accident, and she was in plaster. And she'd been put on Ativan by the surgeons, the orthopedic surgeons, for muscle relaxation. And she said, you know, I can't get off this drug. I'm starting to crave every time the next dose is due. I think I'm addicted. Can you help me? Well, I was young and naive in those days, and I said yes. But it was difficult. But after her, there was a stream and then a flood, a torrent of patients coming in saying these benzos don't work anymore. They were super at first, but now I'm getting more anxious and all sorts of other things. And so that's how this clinic started. We had to devote a whole clinic just to benzos. In fact, I ended up doing it 2 sessions a week for years. And no other pharmacologist in that group wanted to take on those patients because they didn't like listening to people who said, oh, I'm anxious and, I'm this and that. And it's sort of, the doctors got defensive. So I got all those patients and I just listened, and they told me what to do, and they taught me about withdrawal and, the ways to do it, and we had many trial and errors. But that's how it all started. So it's patient power that moves things. And I'd be very interested when we've heard Joanna, with any questions and experiences that you've had.
I'm Joanna Moncrieff, and I'm a psychiatrist, and I've had a long-standing interest in psychiatric drugs. I'm supposed to be on a microphone, but oh, that's just for the filming, right. I'm a psychiatrist. I've had a long-standing interest in psychiatric drugs. And I've been trying to promote the idea of looking at psychiatric drugs, as psychoactive drugs, and trying to work out what they actually do to the body and how the body responds to them, rather than seeing them as they're often portrayed as disease treatments that just rectify an underlying abnormality. So what I'm suggesting is that instead of rectifying an underlying abnormality, drugs actually create an abnormal state. They create an altered state. And we're quite comfortable with that idea with drugs of abuse like alcohol and heroin and things like that, but maybe not so comfortable with that idea with psychiatric drugs like SSRIs and antipsychotics. And the work I've done on coming off psychiatric drugs relates to 2 things. Heather was talking about how patient power really demonstrated the addictive potential of benzodiazepines. And it also has really demonstrated, and David Healy's been very involved in this, the addictive potential of SSRIs. And really that has, I think, brought home to everyone that all psychoactive drugs are potentially addictive, that there are withdrawal effects, there are potentially withdrawal effects after coming off any sort of drug that alters the way the brain functions, including drugs that we wouldn't normally think of as psychoactive drugs, like things like steroids have withdrawal syndromes. And I looked at the literature on coming off antipsychotic drugs, And there have been some suggestions over the years that some people, when they come off antipsychotic drugs, get a psychotic reaction, which is induced by the withdrawal. And this idea had been around in the literature for about 20 years, but not really accepted or believed. So I collected together all the literature on that and managed to convince myself anyway that this certainly does occur, and I think it occurs most frequently with clozapine, and the literature on clozapine really makes it undeniable that there is something like this in quite a high proportion of people who come off clozapine, and maybe a lower proportion of people coming off other antipsychotics. And the other thing that's interested me about coming off psychiatric drugs of any sort is how often I think the main difficulties to coming off are to do with the system and the importance that the system puts on taking drug treatment. And I work with, I'm a rehabilitation psychiatrist. I work with people who have had psychiatric problems for many, many years, often very severe ones, and who are on large amounts of drugs that they almost certainly don't need and haven't benefited from. And yet it is very, very difficult even to try and reduce those drugs because of the resistance from the staff and the whole system, really. Or sometimes as well from the patients themselves, who have been used to being very, very drugged for many years and find it difficult to face the idea of life without drugs or with a lower level of drugging.
Millie actually asked me to write 10 golden rules for people coming off prescribed medication. And interestingly, I felt the medical profession would probably say the first rule should be speak to your doctor. But I actually put that second because I actually think the patient needs to have some information about what they want to achieve and how they're going to achieve it before they go to the doctor and before the doctor gets it wrong, and they can then go in armed with the information and then share it with the doctor. And I think that's a sad fact that we have to actually research our own stuff and then take it to the doctor, who actually should have that information there. And I think that's goes very well with what we're all saying, really.
Well, I always used to tell my patients they should treat their doctors like they treat their garage mechanic who services their car. And there is a list of 10 questions in the thing. And to ask any prescribing doctor before you take the drug, such as, why am I having this drug? What does it do? Are there any side effects? Does it interact with other drugs, etc.? Any withdrawal effects? There's a list somewhere. Because after all, the doctor's servicing your body, and it's your body. So I think that the patient should have the right to know exactly what is desired. And as Joanna said, many doctors use drugs just as treatments. You've got this, so you take that. And they don't think, what is it actually doing inside? And that's, of course, an interest for everybody, and pharmacologists too.
Well, I think it's the problem that we look at these drugs in the wrong way, not as drugs, and people, GPs and psychiatrists in particular, are not encouraged to see them as drugs and think of what they do to the body and how that might impact on symptoms, but are simply trained to think, right, you have this problem, you need this treatment. And I don't think it's like that at all.
Yeah.
Would you like to speak?
No, I was thinking, Joanna, that really in the training when people go to be doctors, there needs to be far more input into how these psychoactive drugs do affect the mind and the body. And if it was incorporated into training, then GPs, psychiatrists, etc., might take a different view. And I think it's very difficult when somebody's being prescribed an SSRI and they have an adverse reaction and they go psychotic and they land up into the acute ward. They're in no state to ask the psychiatrist why are you giving me these and what are going to be effects on my body and my mind long term, let alone me as a carer who is in a complete state of shock. And of course the unfortunate thing is that when you get the side effects of psychotropic medication, a lot of them, I'm not talking about the physical ones particularly, but the psychological side effects actually mimic the conditions in the first place, which just reinforces the psychiatrist's belief that these drugs need to be perpetuated. And I feel that psychotropic drugs are a different kettle of fish from the benzodiazepines, because many people are in a different position, and the neuroleptic drugs just completely blotto people's minds. They've got no motivation to ask anything. Their thinking goes all obscure, and they're not able to ask the pertinent questions that a person who's been on diazepam and benzodiazepine might.
Well, I think a lot of people on benzodiazepines are also affected that way. Yeah, I mean, that, you know, there are some people are still quite confident on them, but there are many people who are not able to ask questions and become very withdrawn. I should mention that I have recently restarted doing training days for medical students in Liverpool, and I'm hoping to do it in other universities across the country. But it is quite stunning to think that if I didn't do that, they would actually get no information on benzos and other mind-altering medication.
Can I add to that? It's well documented that the pharmacology lectures for all health professions, pharmacists, nurses, and particularly physicians, because of the how much has to be crammed into the courses now, that the actual pharmacology lectures have, in some cases, in some medical schools, have been cut by about 20% over a decade.
And there wasn't much to start off with.
There wasn't much to start off with, so it's even less now.
Yes.
So that, to actually add in psychiatric reactions to medicines.
It's quite unbelievable, really, isn't it?
Yeah.
Lady at the back, sorry.
Can I just say,
Yeah.
it starts before the training. There isn't enough, the knowledge base is not there.
That's right.
The right sort of research has not been done, because all people have been concerned about is looking, does it affect these symptoms, a very narrow range of symptoms, and does it affect this particular receptor that we think is relevant? So all the other receptors that drugs affect and all the other effects are ignored. We don't know what sort of withdrawal reactions most drugs produce. We don't know how long they go on for. We don't know whether they might persist when the drug for many months or years, even after the drug is stopped. Or none of these things have been adequately
The
looked
physical
at.
consequences of the drug, such as say propranolol or a beta blocker, most people will know that it causes bronchoconstriction. You don't give it to asthmatics, but then very few people know that it causes hallucinations, weird dreams at night time, because it's a fat soluble gets in the brain. So, I mean, they seem to know a lot of the physical consequences of the drug that use, but not the psychiatric, even basics.
Lady at the back in the grey cardigan.
Thank you. I've got 2 points. First of all, as a carer, GPs are the gatekeepers to all services, and the buck stops with them, really. If you're trying to access appropriate services, you've got a problem there. Secondly, when a person presents with a problem, full histories aren't taken, and very, very rarely are endocrine problems investigated and properly tested. And even if you're given under the NHS thyroid or adrenal or DHEA sort of testing, they only test the blood, which is often found to be normal. It doesn't actually test what's being metabolised and used in the body. And we have case at home where, when that private testing was done, which was more appropriate, it identified huge problems which explained some of the apparent mental health symptoms, but they were of a physical origin due to a completely disrupted hormone system. No one would investigate it. The GPs are still refusing to accept those test results and the possible consequences of that. So patients and families who are compromised financially anyway are having to go to the private sector, and that's dangerous in itself. You have to be really responsible and very careful to make sure you do that responsibly, and that isn't easy.
Well, who would like to answer that, Joanna? Do you think?
It depends what drugs you're talking about and what problems you're talking about. And if you want to stop people talking about their symptoms, quite a lot of these drugs can do that quite effectively. Especially antipsychotics. Whether, obviously that's not really helping the underlying problem. And